So someone wanted to know a little bit about neuro-ophthalmology and sickle cell disease. And one of the irritating things about this sickle cell disease is that is the same thing as SC disease. And so you don't want to get confused between sickle and sickle cell and the SC genotype. So as you know, these are inherited hemoglobinopathies. The abnormal amino acid substitution leads to conformational change in the protein. That part you don't need to know. What you need to know is normal adult hemoglobin, the normal wild type genotype is AA. If you carry the sickle trait, you are AS, but you're still asymptomatic, you're just a carrier. And the homozygous form, SS, but there's this SC, which is a different amino acid substitution. So what you have is a different mutation. This is a compound heterozygote. You can also have the S-thal variants. And amazingly, it is the S-thal and the SC that produce the proliferative diabetic retinopathy-like appearance. So it looks like diabetes, where you have non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. In sickle cell, we have non-proliferative sickle retinopathy and proliferative sickle retinopathy. And the proliferation is driven by VEGF, vascular endothelial growth factor, leading to the formation of the neovascularization. And so the way this comes to us is both retinopathy and hyperviscosity and strokes in the brain. So that's what we should be thinking about in sickle patients. In the homozygous sickle cell disease, SS, they can have vaso-occlusive events that lead to pain crises. They have to be admitted, have hydration. And in the S-thal and SC, and in the SS, we see the proliferative and the non-proliferative sickle retinopathy. However, in the SS disease, because it's more ischemic in the periphery, it causes an autoinfarction that kills the VEGF source. So we actually see more proliferative retinopathy in S-thal and SC than in the SS disease. The AA is the wild type, the AS is sickle trait, they don't come to us. And so we've got different problems. One is the hyperviscosity problem, where you get vaso-occlusive events that can present to us as stroke in young people who have SC, S-thal, or SS. And we've got the problem with vascular remodeling caused by these micro-occlusive events, and that can lead to secondary aneurysm formation. We also have the problem of the sickle retinopathy in the eye itself. The retinopathy can cause a hemorrhage, which can look like a piece of salmon, a salmon patch. And once you get the scar in the area of the hemorrhage, that chorioretinal scarring is called the black sunburst. It is the remnant of the inflammatory and hemorrhagic event at the level of the retinal pigment epithelium with hyperpigmentation. And in the periphery, because of the VEGF, we get a CFAN of neovascularization at the border zone with the ischemic retina. And it is this ischemic retina that is producing the VEGF. So the treatment of proliferative diabetic retinopathy and proliferative sickle retinopathy are parallel. We're trying to eliminate the VEGF. We might do pan-retinal photocoagulation, or we might do anti-VEGF agents for the treatment of the proliferative form of sickle retinopathy. In the brain, the hyperviscosity and vaso-occlusive events can cause afferent disease, homonymous hemianopsia, or efferent disease, diplopia, from patients with sickle. And you should know that S-thal and SC actually are more likely to produce the proliferative findings in the retinopathy, because SS causes autoinfarction of the peripheral retina, leading to killing of the dead ischemic retina and a reduced chance of VEGF with secondary neovascularization. So you need to know a little bit about the neuro-op of sickle cell disease.